Finals SAQ88, Autistic Spectrum Disorder. A 5-year-old boy with ASD is listed for dental extraction as a day case. What constitutes autism spectrum disorder, and what are the key clinical features? ASD is a lifelong condition affecting brain development with impact on communication, social interaction, abstract thought, and there is reduced IQ in about 50% of cases. Key clinical features include communication problems, such as language delay, avoidance of conversation, failure to understand nuances, and literal interpretation. Features in interaction, lack of eye contact, reduced social interaction, low understanding of usual rules of social interaction, intolerance of people entering their personal space, and minimal use of gestures. Abstract thought, inability to generalize information, unable to appreciate that different people have different thoughts, problems with knowledge and beliefs, and inability to understand metaphorical explanations. Behavioral, presence of routine and repetitive behaviors, and distress if routines are broken. Presence of highly specific interest for particular subjects or activities, and rigid food preferences. B. List the important issues when providing anesthesia for dental extraction in children. Organizational, proper hospital setting is required, offering the same standard of care as for other cases requiring general anesthesia. Availability of pediatric anesthetic equipment. Staff trained in care of pediatric patients including resuscitation. And facility for preoperative assessment in advance in select cases. Preoperative. Pre-op assessment will usually be done on the day of admission. Careful questioning to ensure fitness for procedure, with good explanations for consent. Pre-medication, including topical local anesthesia for cannulation. Consider anti-sialagogue. Place specialist or psychologist involvement, especially for children with special needs or specific fears. Well-managed induction to maximize cooperation. Strategies for uncooperative children. This includes pre-medication, for example, with oral midazolam, oral ketamine, intranasal Presidex or IM ketamine. Parental presence may help. Intraoperative issues includes shared airway, small airway, blood from extractions may result in inhalation or laryngospasm, throat pack, risk of dislodgement of airway with surgery or gag, and head-up position, risk reduced cardiac output and cerebral perfusion. Post-operative issues, risk of laryngospasm in recovery due to blood in airway, pain management, NSAIDs and paracetamol are usually sufficient. Some children resist taking oral medication if there is oral pain following dental work. Management of nausea and swelling, for example with dexamethasone and ondansetron. Antiemesis and analgesia must be sufficiently well managed for day case procedure to facilitate early post-op eating and drinking and discharge. C. If the specific problems of providing anesthesia for children with autism and outline possible solutions. Distress due to unfamiliar hospital setting may make it difficult to perform pre-op assessment on day of admission. It may be necessary to do this in the community, including weight measurement. Provide quiet and separate waiting area. Second problem, language issues may make it difficult for the child to comprehend what is to happen. Use appropriate visual information. Place specialists or psychologists to enhance comprehension. Information provision in advance. Lack of familiarity with environment, out of routine, which may cause distress. Solution: maximize the familiarity of the environment, minimize disruption of routine by allowing own clothes, familiar objects, parents, familiar carers, and minimize waiting time. Give clear timetable of day ahead and stick to it. Next problem is pre-op starvation, may be poorly tolerated as it breaks the routine. Solution: put the patient first on the list. Allow clear fluids, maximum 3 ml per kg up to 200 cc until 1 hour before surgery when appropriate. Next, the patient may dislike physical contact. Keep it to a minimum. Warn prior to physical contact. Topical local anesthetic may not be tolerated. Thus consider inhalational induction. Consider staffing requirements for this. Next problem is lack of cooperation. Discuss in advance regarding physical restraint. Consider induction after pre-medication. Dysphoric response to midazolam is possible in autism. Consider whether pre-medication is necessary. Consider combining midazolam and ketamine. Next problem is inability of the child to communicate likes and dislikes. Solution: utilize the parent's knowledge of the child to anticipate problems. Use of communication passport. Overall 46.2% pass rate. Autism and anesthesia. Introduction. Definition of autism. Autism is a lifelong neurodevelopmental difference that influences the way a person interacts and communicates with others and experiences the world around them. These differences may manifest as unconventional social communication or social interaction, sensory sensitivities, and focused interest and repetitive behavior. Autistic features share common themes, but each individual will present with a personal profile of strengths and challenges, which fluctuate according to circumstance. Epidemiology: at least 1 to 2% of people are autistic. Most are adults without intellectual disability, and many are unrecognized. Autistic people are more likely to have co-occurring medical conditions, such as obesity, diabetes, hypertension, dyslipidemia, Parkinson's, immune-related disorders, GI disorders, sleep disorders, mental health conditions, such as depression, anxiety, self-harm, suicide, and ADHD, hypermobility syndromes such as Ehlers-Danlos, autonomic dysfunction, and chronic pain. Autistic people experience well-described barriers to healthcare, adverse health outcomes, and premature mortality. Delayed presentation is common. Person-centered adaptations improve experience of perioperative care. Autistic Space (SPACE) offers a framework for meeting the needs of autistic patients, where S stands for sensory needs, P for predictability, A for acceptance, C for communication, and E for empathy. The Autistic Space Framework. Sensory. This includes sight, sound, smell, taste, touch, temperature, and pain. Sight. Visual sensitivities are common. Reduce anesthetic room lighting and induce in anesthetic room rather than theater. Sound. Auditory sensitivities and auditory processing differences are common. Reduce background noise. Avoid multiple people talking to the patient at once. Allow or suggest the use of noise-cancelling headphones and earplugs. Smell. Autistic people are often highly sensitive to smell. They may perceive odors that others do not. Avoid strong smells if possible, such as cleaning products or air fresheners. Taste. Respect sensory preferences, such as when using liquid medication. Consider preferences for inhalational or IV induction. Touch. Ask about tactile preferences. Modify examination technique accordingly. Avoid casual touch. Consider allowing own clothes to theater with gown over the top. Use of sensory aids such as weighted blankets. Temperature. Sensitivity to temperature is common. Consider environmental temperature and individual thermal preferences. Offer or avoid additional blankets or forced air warmers as preferred. Internal sensations and pain. Ask directly about internal sensations, but understand that answering may be difficult. Some autistic people have difficulty interpreting internal bodily sensations. This can lead to difficulties noticing hunger, thirst, tiredness, and a need to urinate or defecate. Acknowledge and address any complaints of pain, even if they do not appear in pain. Adapted pain scales may be required. Patients can sometimes have reduced or increased pain sensitivities. There might be difficulty in communicating their pain. P. Predictability. Give written information in advance, for example, accurate signs or maps. Explain carefully what to expect and be as accurate as possible with time frames. Allow opportunity for a tour before surgery. Allow waiting in a familiar environment if possible. Ensure care is provided by staff familiar to the patient where possible. A. Acceptance. Due to neurodiversity, affirmative approach is beneficial. Understand autistic stimming and monotropic thinking patterns, facilitate the need for detailed factual information, understand distress behavior. C. Communication. Understand autistic verbal and non-verbal communication differences. Know that communication ability is reduced by anxiety and sensory stress. Use clear, unambiguous communication. Promote the use of augmentative and alternative communication. E. Empathy. Recognize that autistic people feel empathy but may display it differently. Empathy towards autistic patients may be more challenging for non-autistic healthcare providers. Consider physical space, temporal space, and emotional space. Allow for increased personal space. Avoid proximity to other people where possible. Allow increased time to respond to questions. Allow increased time for decision making. Expect differences in emotional expression. Allow space to recover without additional input if distressed. For further info, kindly refer to the article by Brown et al. In 2024. Autism and Anesthesia, a Simple Framework for Everyday Practice, BJA. Pediatric anesthesia, challenges with induction. 6 potential challenges when inducing pediatric patients includes the anxious child, the child with a behavioral disorder, the resistant child, restraint and consent, the unfasted child with potential full stomach, the child with difficult IV access, and the unstable or unwell child. The anxious child. Children who are distressed at induction are more likely to experience distress on emergence and post-op period. Risk factors for pre-op anxiety includes previous behavioral problems due to healthcare encounter, more than 5 previous hospital admissions, anxious parents, and behavioral disorders such as autism, ADD, and ADHD. Age-specific considerations. For those 0 to 12 months old, they demonstrate general distress. They do not demonstrate fear responses yet. They respond to separation with soothing and distraction. Pharmacological anxiolytics are seldom required. For those aged 1 to 2 years old, there is increasing attachment and fear, increased mobility and strength. Distraction techniques are beneficial. Pharmacological anxiolytics are seldom required. For those 2 to 5 years old, there is increased separation anxiety from parents. There is increased physical strength and inability to rationalize behavior. Pharmacological anxiolytics may be required in this age group. For children 5 years old to adolescents, there is increased sense of self and potential harm. They may respond to explanation and reason. Distraction techniques are beneficial. Risk factors for anxiety in adolescents includes baseline anxiety, depression, somatization, and fearful temperament, which may necessitate anxiolytics. Anxiolysis techniques may be non-pharmacological or pharmacological. Non-pharmacological techniques includes parental interventions, passive child interventions, interactive child interventions, mass introduction, and parental presence. Parental intervention includes education with videos, leaflets, pre-admission visits, pre-admission tours, familiarization with anesthetic techniques, such as face mask or cannula. Passive child interventions may involve reducing the number of personnel in the OT, avoiding bright lights and loud sounds during induction. Interactive child interventions includes education about surgery and anesthesia and the equipment used, for example, using pre-operative coloring books, stories, videos, website or tours. Age-appropriate effective communication is important. For example, engage in conversation about recent birthday, holiday or vacation. Age-appropriate relaxation tasks may be possible, such as deep breathing exercises. Distraction techniques may involve toys, books, videos, music, games, storytelling, joke-telling, singing, magic, clowns, and virtual reality. Regarding mask introduction, ask the child to choose mask flavor, color, or flavor the mask with lip balm. Regarding parental presence, cultural, religious, and ethnic variations influence impact. Pharmacological techniques. Practice of pre-medication is heterogeneous and depends on institutional policies and culture. Key factors for safe and successful pre-medication: consider possible contraindications such as difficult airway, risk of hypoventilation such as in OSA, obese or reduced conscious level, risk of aspiration such as those inadequately fasted or emergency surgery, critically unwell patients who are allergic to pre-medication, and presence of end organ dysfunction such as liver or renal failure. Give pre-medication enough time to work. Provide adequate monitoring facilities. Select appropriate agents based on previous experiences, severity of anxiety, behavioral disturbances, and comorbidities. Consider combination therapies using lower doses for each agent, such as oral ketamine plus midazolam or oral ketamine plus clonidine. This table lists the medications used for pre-medication in pediatric anesthetic practice, which includes benzodiazepines such as midazolam, diazepam, and temazepam, NMDA receptor antagonists, ketamine, alpha-adrenergic agonists such as clonidine and dexmedetomidine, and others such as melatonin and trimiprazine. Strategies to avoid mask rejection during inhalational induction. Avoid forcefully holding down a child with a face mask with 8% sevoflurane. Techniques to avoid mask rejection includes gradual sevoflurane induction, inhalational induction using cups of hands if the child is afraid of the mask, occluding the child's nares from sevoflurane by rotating the face mask 90 degrees so that the cuff occludes the nares, and single breath induction of anesthesia if the child understands how to hold their breath. Next, we move on to the child with behavioral disorders. A wide range of behavioral disorders exists, such as autism, ADD or ADHD. Some children may not have a specific diagnosis. Parental reporting of difficulties with behavior should be considered when planning the perioperative period. Discussion with the parents regarding behavior and compliance is important to assess the likelihood of cooperation. Ask about usual rituals and routines of the child, and how these can be disrupted as little as possible. Ask the parents about signs of the child becoming upset, any specific triggers, and what strategies the family use to try to ease the situation. Regarding children with autism, this has been discussed in the previous section. Regarding children with ADHD, they can be less cooperative at induction and have a greater incidence of post-op maladaptive behaviors. Children with ASD, ADD, and ADHD can be on a wide range of psychoactive drugs and stimulants. There have been case reports of increased drug requirements of sedation and anesthesia, and various hemodynamic effects, such as refractory hypotension with risperidone. There is currently no clear evidence-based guidelines on perioperative management of stimulant medications, and the decision is usually made by the prescribing doctor and the parent or guardian. Next, we move on to the resistant child, restraint and consent. Children are often reluctant to have a stranger hold a mask on their face or insert IV cannula. Local policy and laws will dictate requirements for consent. In the UK and Australia, the law surrounding consent in children is guided by the concept of Gillick competence, where in order for the child to withhold consent, the child must have sufficient understanding and intelligence to enable him or her to fully understand what is proposed. The 2003 Working Group of the Confederation of European Specialists in Paediatrics, CESP, stated that children may effectively refuse treatment or procedures that are not necessary to save their lives or prevent serious harm. There are a limited number of specific guidelines on restraint in pediatrics. Local policies should be consulted to ensure local protocols are adhered to. Most guidelines emphasize the importance of explaining this type of intervention to the child and their parents, and ensuring that the child is not injured in any way during the process. The competent child also has the right to refuse a treatment or intervention. In Malaysia, the 2016 Guidelines on Management of Aggressive Patients states that the behavioral approach de-escalation techniques is preferable when managing aggression in children and adolescents. In Malaysia, there is currently no regulation on the use of restraint on children and young people. However, the Human Rights Act and capacity assessment must be considered when the use of restraint in this population is planned. The healthcare provider should be aware that physical restraint can result in a child feeling out of control, becoming anxious and distressed. Restraint is not allowed for children below the age of 12 years old in psychiatric facilities. Separate consideration is given to medication choices, dosages, and route of administration. Parents must be informed of the management. The American Society of Pediatricians statement on the use of physical restraint in the acute care setting defines restraint as physical or mechanical methods to restrict movement, and therapeutic holding as physical restraint of a patient by at least 2 people to assist the patient who has lost control of behavior to regain control of strong emotions. The UK Royal College of Nursing Restrictive Physical Interventions and the Clinical Holding of Children and Young People 2019 defines restrictive physical intervention as any method which involves some degree of direct force to try and limit or restrain movement. It should be necessary, proportionate, and justifiable, and only used to prevent serious harm. Any use of planned or unplanned restrictive physical intervention should be carried out using the least restrictive interventions for the minimum amount of time. Clinical holding means using limited force to hold a child still. It may be a method of helping children with their permission to manage a healthcare procedure quickly and effectively. Alternative terms include supportive holding, holding still, therapeutic holding, and immobilization. Clinical holding has been distinguished from restrictive physical intervention by the degree of force used, intention of the hold, and the agreement of the child, but should still be considered a restrictive physical intervention. Be aware that clinical holding, if applied without the child's assent, can result in anxiety and distress. General principles for good practice. Principles for good practice for clinical holding. Principles for good practice for restrictive physical intervention are included here for completion. We move on to the next challenging situation, the unfasted child with potential full stomach. Some clinical circumstances require anesthesia to commence prior to adequate fasting. Children are also more prone to gastric stasis with minimal trauma, opioid analgesia, and pain. The place for pediatric RSI remains controversial. At times, even when RSI is indicated, performance is impossible, for example, due to difficult IV access or non-compliance with pre-oxygenation. In this setting, attempts should be made either to site an IV line prior to induction or minimize disturbing the patient during an inhalational induction prior to IV cannulation. It is important to have suction available and voice concerns about potential aspiration to other staff. The anesthetist should ensure the airway assistant is comfortable performing cricoid pressure. Next, we move on to the child with difficult IV access. Careful assessment of venous options prior to any attempts will allow selection of the best site. Application of topical LA can be used to reduce pain associated with cannulation without negatively impacting success rates. Use of specialized lights for vein identification or trans-illumination in infants can be helpful. Ultrasound can be of use if available. The anesthetist has the expertise and the patient is cooperative. Consider use of hockey stick ultrasound linear probe where appropriate. Consider alternative routes such as intramuscular for ketamine and intraosseous route. It is well known that cannula placement is easier in the anesthetized child, hence an inhalational induction may be preferred in patients with history of difficult IV access. While not routine, in a child with difficult access, some anesthetists will perform airway instrumentation without IV access. The key to this approach is ensuring that the child is sufficiently deep and standby a dose of IM suxametonium 4 mg per kg to facilitate paralysis where appropriate. The next challenge is the unstable or unwell child. Increased work and sympathetic surge associated with being stressed or upset prior to induction can cause clinical decompensation in unwell or unstable children with limited physiological reserve. This can occur before induction agents have been given. Alternatively, the critically ill patient may make little attempt to fight induction, which is a marker of how unwell they are. Cautious pre-medication in a monitored and supervised environment may be appropriate and may decrease the induction doses required. Preparation is again vitally important in these patients. If possible, attach monitoring prior to induction. Ensure resuscitation drugs are immediately available. When giving any agents, start low and slow, using small doses slowly titrated to effect. Propofol is used less commonly in these circumstances. Many anesthetists favor agents such as ketamine, midazolam, fentanyl, and remifentanil. For further comprehensive summary, for induction in sick children, please refer to ATOTW 169. Next, we move on to the restless child in the recovery room. Introduction. Restless children in recovery room is distressing, not only for the staff, but also for the parents, more so when it results in physical harm, dislodgement of IV access, drains, and catheters. This often creates a false impression of the quality of the anesthesia provided. Before attributing restlessness to emergence delirium, other serious causes should be excluded. Possible causes for restlessness or agitation in the recovery includes pain, hypoxia, hypercarbia, airway obstruction, hypoglycemia, CNS disease such as seizure or raised ICP, electrolyte imbalances, especially hyponatremia, temperature abnormalities, drug-related causes such as residual anesthetic, extrapyramidal effects, especially from some antiemetics, inadequate reversal of muscle relaxants, need for micturition or defecation, thirst, hunger, fear, anxiety, underlying behavioral disorder such as autism or ADHD, sepsis, and emergence delirium. Regarding emergence delirium in children, this is a state of post-op confusion and disorientation associated with restlessness, involuntary movements, and inconsolability. Symptoms include agitation, hyperactivity with flailing movements, confusion, failure to recognize or engage with people and the surroundings, behavioral changes such as thrashing, screaming, prolonged crying, and combativeness. Time course. This is usually self-limiting and short-lived. It occurs within the first 30 minutes after anesthesia. It can last from few minutes to few days. Incidence 20 to 80% in pediatrics. Risk factors for emergence delirium includes patient surgical and anesthetic factors. Patient risk factors includes preschoolers aged 2 to 5 years old due to psychological immaturity, male gender, pre-op anxiety, previous surgery, parental anxiety, and child temperament. Surgical risk factors includes surgery in the head and neck areas, especially tonsils, thyroid, teeth, ears, and eyes. Anesthetic-related factors, use of sevoflurane or desflurane anesthesia due to rapid washout and emergence. Management of emergence delirium. Review the patient in recovery with their anesthetic chart and a full set of bedside observations, including blood glucose level and temperature. Identify and treat treatable causes. Ensure patient safety, exclude physical discomfort, provide reassurance, reunite the patient with the parents, reassure the mother, and encourage her to try and soothe the child by holding him on the bed if appropriate. Consider placing the child in a quiet corner in the recovery with familiar faces. Ensure adequate analgesia has been given and prescribed perioperatively. Escalate to senior pediatric anesthetists and/or surgeons if any concerns are present. The Pediatric Anesthesia Emergence Delirium Scale can be used in identifying and monitoring the severity of ED once alternative pathological causes have been eliminated. Parameters in this scale includes eye contact, purposeful actions, awareness of the surrounding, restlessness, and inconsolability. Pharmacological treatment should be undertaken if there is potential risk for self-injury, such as IV fentanyl, propofol, or midazolam. Prevention of emergence delirium. Identify those at high risk of ED and modify anesthetic technique. Reduce parental and child pre-op anxiety by giving preemptive preparation and also pre-medication to anxious children if necessary. Parental and child education preoperatively, including play therapy, pre-op assessment, and familiarization with anesthetic technique may help. Ensure adequate analgesia. Consider regional technique whenever possible. Tiva with propofol has been shown to reduce the risk of emergence delirium. Drugs given below have been reported to be useful for prevention and treatment of ED. Note that these preventive strategies increase sedation and may delay discharge from PACU. Examples of drug used to prevent ED includes propofol, midazolam, clonidine, Presidex, fentanyl, alfentanyl, dexamethasone, and ketamine. These are my references. Thank you.